Good afternoon, everyone. My name is Stephanie Romano, and I'm the Education Coordinator with SWORBHP. Welcome to another webinar presentation. Today we'll be talking about excited delirium. Our presenters today are Dr. Matt Davis, who is our education physician here at SWORBHP, and also Megan Muchacho, who is a PGY3, an emergency resident. If you're new to webinars with us, you'll be watching the PowerPoint presentation and hearing two presenters speak. You'll also have the opportunity to ask questions, and you can do that by two ways. You'll see a control panel, probably on the right-hand side of your screen, with a hand icon. So that hand icon allows you to put your hand up and let us know that you have a question. If you do that, you should have a microphone as well, because you'll be able to ask questions live, which we'll reserve to the end of the presentation. If you happen to have questions throughout the presentation, there's also a question box or chat box. It should be at the bottom of your control panel, and you can type in there any questions you have throughout the presentation. Some of those questions I can answer in the background throughout the presentation. Otherwise, I will present them to our presenters, and then they can answer those questions live so that everyone can benefit. And so, without further ado, I will hand the presentation over to Megan and Matt. Sounds like we might be having some technical difficulties, so sit tight, everyone. Just give us a second and we'll try and figure this out.
Can you hear us now?
There we go.
Oh, there we go.
That's better. Okay,
so this,
I did your intro, and you guys are good to go.
Okay, thank you. I'm just going over the objectives. So we're going to be talking about excited delirium today. So we're going to talk a bit about the signs and symptoms of excited delirium and what these patients are going to look like when you encounter them in the field. We're going to talk about the pathophysiology that underlies excited delirium, and we're going to talk about how you can manage them in the pre-hospital setting, as well as what happens when these patients come into the emergency department. And then we're going to talk a little bit about the association between tasers, or conducted energy weapons, and morbidity and mortality in excited delirium patients.
Hopefully this is a beneficial topic for everyone. There are definitely pockets here in Ontario where we're seeing more sympathomimetic abuse, crystal meth, and seeing a rise in the amount of patients who are suffering from excited delirium. So hopefully you'll be able to learn from this and provide better care for the patients that are suffering from this, as well as kind of keeping it on your differential for patients who may be suffering from something else but can present very similar to excited delirium.
So excited delirium has been described a few different ways. It was first discussed in 1849 by a gentleman with the last name of Bell, who called it acute exhaustive mania. And then it wasn't until 1985 where it was recognized in the U.S., where a Miami physician, this was kind of during the height of the cocaine epidemic in the States, described this kind of syndrome in a cocaine body packer. And then it wasn't until 2009 that it was formally recognized by the American College of Emergency Physicians as what we describe excited delirium today.
And you'll notice that a lot of the literature actually revolves around cocaine use. A lot of the studies in cocaine, because again, first described in the 1980s, 1990s when cocaine was at its height, but now, you know, with the evolution of street drugs, we've got things out there like PCP and crystal meth. So again, a lot of literature talks about cocaine, but these are all sympathomimetics and you know, probably all interchangeable when it comes to as the inciting event for excited delirium. So anything that ramps up people.
Yeah, so people on meth, PCP, cocaine, they'll all exhibit
bath salts.
Bath salts. Yeah, they'll all have this kind of presentation. So how these people present can vary in a few ways, but they all have a similar agitated presentation. So it's whenever they're intoxicated with those sympathomimetic agents, they might be acting bizarrely. They'll often be taking off their clothes, screaming, they'll be sweating. They might be exhibiting symptoms of psychosis. For example, hearing voices, be quite paranoid. And they're often quite violent. They might be ripping through fences or throwing tables around. And it does seem that they exhibit a superhuman type of strength when they're under the influence of these drugs. And their speech might be incoherent, and oftentimes these patients are being tased by police or taken down by police, and it seems like the pain isn't even affecting them, and they'll continue to struggle despite being restrained.
And there's a lot of YouTube videos out there where you can just kind of do a Google search for excited delirium and see these types of patients presenting. And it's incredible how much strength they actually do have. It usually takes anywhere from 5 to 10 police officers to take them down. They get tasered multiple times, and they keep going. Another interesting kind of component of this is you'll notice in a lot of these videos that they're actually naked, running around naked. So no one really knows the reason why they have this propensity to take their clothes off. That's thought to be related to their hyperthermia. They're just overheated. They recognize that, and off come the clothes. So some crazy videos out there. If you afterwards you want to take a look at some of them just to get an idea if you haven't seen this before. It's something that is quite incredible to see.
And these patients will also have abnormal vital signs. If you're able to get an assessment on them, they'll be quite tachycardic, their blood pressure is going to be elevated, their temperature will be elevated, and they'll be quite tachypnic as well. But again, it might be a bit difficult to get a blood pressure on a lot of these patients.
Usually impossible to get these objective findings in these patients when they are in their excited delirium phase. Once they are eventually calm, be it by chemical restraint, you will notice that these abnormalities with their vital signs. But again, pretty much impossible to discern these in the state that they are in.
So this is just the description by the American College of Emergency Physicians Excited Delirium Task Force, and this was described in 2009. So they kind of look at the typical case of excited delirium as someone who's acutely ingested some kind of drug, a sympathomimetic. They might have a history of mental illness. They're in a struggle with law enforcement, and they seem to be impervious by these physical or chemical control measures. And a lot of times these patients will all of a sudden have an unexpected death. And when this is looked at in autopsy, they really can't find any trauma or other disease process that's resulted in their death.
So yeah, it's a bit of a black box when it comes to both the pathophysiology of why certain people, when they're on these sympathomimetics, have excited delirium versus other people can have a whole career and never experience excited delirium when they're using their sympathomimetics. And again, when it comes to these deaths, it's still a bit of a mystery as to why. There's definitely theories out there as to why they may have these sudden cardiac arrests. But again, still a black box that is being explored.
So as for the pathophysiology behind excited delirium, again, it's not yet fully understood. It's thought that the dopamine transport is dysregulated by the sympathomimetics that these patients are ingesting, and that it blocks the transporters to the dopamine, increasing the amount of dopamine at the synaptic cleft. So they're just continually being stimulated by this. And dopamine affects a few processes in the body. One of them is thermoregulation at the hypothalamus in the brain.
And this would explain why they do become so hyperthermic because of that dysregulation.
And it doesn't seem to be dose dependent on the amount of drugs they're taking. They've looked at post-mortem studies in patients who have died, and this was looking at cocaine, but again, it can be a number of different sympathomimetics. And this one study found that these patients had a cocaine concentration similar to people who have used recreationally, but less than those who have been found to have died because of a cocaine overdose. So it's not that they're overdosing on these medications.
So yeah, it's definitely not a dose response. The more you take, the more likely you are to have excited delirium. So, potentially a genetic component that some people are just genetically more predisposed to this. Again, not understood fully at this time.
So we look at why do patients with excited delirium die? Is it because they have this excess catecholamine? They're being stimulated by this dopamine? Is it a respiratory arrest, maybe secondary to being restrained? Are they cardiotoxic because of the cocaine use or other sympathomimetic use? Could it be rhabdo from breakdown of skeletal muscle due to a continued struggle or restraint? Or is it from actually being tasered in the field. So we'll look at a few of these, but again, there's really no actual answer as to why these patients are dying. There's multiple factors involved in this.
Absolutely, potentially a combination of some of these factors which contribute to the deaths.
So as for catecholamine excess in these patients, we talked a bit about dopamine. So this hyperdopaminergic state can cause an increased temperature by dysregulation at the hypothalamus. And in 2011, there was a study that looked at a case series of 90 patients who died, thought to be from excited delirium, and they had an average core body temperature of 40.7 degrees Celsius. So they're getting pretty warm with this, and that might be contributing to their deaths. And there's also the thought that the excess catecholamines can cause cardiac stress. So some people with use of sympathomimetics are at an increased risk of cardiac issues. So could it be an acute stress cardiomyopathy? Are they having dysrhythmias? But they have looked into this and found that any ventricular dysrhythmias are pretty uncommon in these patients.
And again, going back to the hyperthermia, you know, we look at something like heat stroke. So when people are at kind of that end of the spectrum where they are hyperthermic, a very dangerous condition to be in. So definitely, you know, probably the hyperthermia is contributing to some of the dysregulation going on at a metabolic level. You know, is that predisposing to arrhythmias? It's hard to say. It's a very difficult patient population to study. So, you know, don't know if there will ever be a firm answer as to what causes these deaths.
And then we look at respiratory arrest in these patients. Could this be another cause of death? So potentially they could have death from respiratory fatigue caused by struggling against restraints or against police when they're trying to be restrained. And a worry with restraints is positional asphyxia. So studies have shown a lack of evidence for actual hypoxia or hypoventilation in restrained patients, but they weren't looking at patients who were exhibiting excited delirium in this study. They were looking at healthy volunteers. So again, it goes with the combination of things that might be causing this. And we'll talk a bit more about restraints later in the presentation too.
And going back to the catecholamines, I mean, they have this huge catecholamine surge, and there's also the thought about a washout too. So finally, all their stores of catecholamines just become depleted. As another thought as to potentially why these patients are more risk for sudden cardiac death or respiratory arrests. You know, they've been exhibiting this superhuman strength. They've got like 8 police officers on top of them, and finally they've just depleted all their catecholamines, and they've still got 8 people on top of them, and they end up having a respiratory arrest or potential dysrhythmia. So a lot of theories out there as to what could be going on.
And then back to restraints, they've looked at a few patients who have died in physical restraint. So they looked at 26 deaths in patients who had been restrained. 3 of them they decided were because of natural causes. And then 22...
i.e. they don't know the reason why.
Exactly.
The good old natural cause.
Natural in quotations.
I'm not exactly sure what natural causes mean, but obviously they didn't have a reason as to why these people died.
Yeah, they couldn't attribute those directly to the restraints.
Correct, yeah.
So 22 of those deaths they did attribute to the restraints, and they thought that 11 of them were from strangulation. So a lot of times people would kind of wiggle out of the restraints and end up with their neck restrained instead of whatever body part was supposed to be restrained. 8 was to compression of the chest, and then 3 were dangling in a head down position. So again, 19 of these were incorrectly applied restraints, which is going to be the majority of these cases, because patients, when they are restrained, shouldn't be able to wiggle out and get into a position where they could potentially die. And they should always be observed for the entire time they're in restraints too, to avoid these things happening. So another theory behind deaths in excited delirium is cardiotoxicity. So cocaine use does predispose patients to coronary artery disease, hypertrophy, myocardial fibrosis. And there could be a thickening of the intramyocardial arteries in cocaine users that could predispose them to ischemia, especially in the setting of increased excited delirium. So they're incredibly agitated, and there's a lot of increased demand. So it could be just too much stress on the heart for these people with potentially compromised hearts as it is.
Again, some of this data is being extrapolated to other sympathomimetic drugs. Like we said earlier, cocaine was kind of, when this was first discovered in the 80s, was kind of the drug they were looking at and studied a lot of, but a lot of this data could be extrapolated to other sympathomimetics and theorized to be the same issue going on with cardiotoxicity.
And then we look at these patients if it's the breakdown of skeletal muscle causing the release of myoglobin, potassium, and other potentially toxic products into their bloodstream, which could result in renal failure, hyperkalemia. So when these patients are fighting and running around and flipping tables over, being restrained, they're going to have a breakdown of their skeletal muscle, and they could be predisposed to rhabdo. And even sympathomimetic use alone can be looked at as a cause of rhabdo because you're in such an elevated state, your whole sympathetic system is ramped up.
Yeah, I get that the danger here would be the hyperkalemia, most likely causing a dysrhythmia, causing the sudden cardiac death with rhabdomyolysis. Again, it's a process that just doesn't happen instantaneously. But these people may be on binges, they're hyperthermic, they haven't been taking in fluids, so they're in acute renal failure just because of that. And then that potassium starts building up as they are in this excited delirium state and wrestling with police officers, and then ending up with a hyperkalemic arrest.
And we'll talk a bit more about hyperkalemia as well a bit later in the presentation. And then the other potential cause of death in these patients that they've looked at is tasers, or conducted energy weapons. And these are used to incapacitate individuals who are quite agitated. And they have done lots of studies on tasers, but most of them are, again, done in healthy individuals. There isn't a lot of data looking at patients who are under the influence of drugs or psychiatric disorders or excited delirium itself.
Yeah, and the thing with tasers, I mean, when they first did it, was more of a correlation, not a causation of these deaths, because often these patients that did end up dying of excited delirium were required to be tased because of the difficulty they had restraining them. So, looking at the literature, tasers themselves are more of a correlation, meaning that they are often used in these patients in excited delirium, but are not the cause of the death itself. Again, very hard patient population to study. A lot of the research with tasers is done in the healthy patient population in terms of randomized controlled studies.
So there are tasers being used by law enforcement in Ontario, and the one that they use is the Taser X26, and so it's powered by a couple of lithium batteries. How it works is that they have compressed nitrogen that shoots out two tethered probes. It has a range of 11 meters, and when these probes do hit the perpetrator, they penetrate the epidermis and the dermis by about 4 to 5 millimeters, and it delivers a current for up to 5 seconds of time when it does penetrate.
And so the fun party fact here, Taser is actually an acronym for the Thomas A. Swift electric rifle. So the inventor of the Taser actually named it after a book that was, I believe, published in the early 1900s. So there's your useless fact for the day that you can try to impress people at your next party and be shunned and sent to a corner.
And so when a taser does hit a person, there are 19 short pulses per second that are delivered, and each pulse delivers 1.76 joules. And over that 5-second pulse that a taser is delivering its electricity, a person receives about 1,200 volts in that short pulse.
So low amperes, high voltage. So it doesn't electrocute people as it would if it were something like a wall socket, which is low voltage, high amperage. You stick a knife into a wall socket, you're going to get electrocuted.
Yeah, it's just enough to incapacitate these people, get them down so that they can then be restrained in a more safe manner. So we have our first multiple choice question that's coming up.
Yeah, so I forgot to mention in my intro, we are doing some poll questions with this webinar. So first one's up there. Taser use results in significant injury in what percentage of deployments? So option A is less than 0.5%, option B 5%, option C 15%, and option D 25%. If you happen to be watching the webinar on a tablet or on your phone and the program won't allow you to actually select an answer, feel free to send that in to me via the question box, and we'll log that as your participation. So we have about 50% of the audience that have voted, so we'll give you a few more seconds to answer. All right, so the results are up. So 77% of you guys attending said that less than 0.5% of people result in significant injury as a result of deployment of a taser.
Yep, that's perfect.
A correct answer there. So they have been shown to be relatively safe devices. When it comes down to safety of both the patient and those responding to the complaint. I mean, it's a gun versus a taser. I think most people would choose the taser.
Exactly, and most of these injuries that they've actually looked at are not really from the electricity from the taser itself. It's more from these patients falling, hitting their head, or from the taser probe entering a spot that it might not have, it might not be preferable. So there's no evidence of any cardiac issues or dysrhythmias for being exposed to the electricity from a taser. And this picture here is an unfortunate individual who actually ended up with a taser probe in his eye. So that's a bit of an emergency there, and we'll talk a bit about taser probe removal as well. So a really important thing to keep in mind when you're dealing with these patients who you think might be exhibiting excited delirium is that it can have a lot of signs and symptoms that are shared with other serious medical conditions. So it's important to not be distracted by their presentation and keep a wide differential so that you don't miss anything that's potentially life-threatening and easily fixed in the field. And here's a list of that, and this is not even a complete list. This is just a few of the more common things. These patients might be hypoglycemic. If you guys have been to a call where someone's got really low blood sugar, you might notice that they can be combative, not themselves. If a family member is around there, they might comment on that. Patients with heat stroke can be hyperthermic, confused, might also be combative. Neuroleptic malignant syndrome and serotonin syndrome are disorders that result from increased serotonin. Usually these patients are on psychiatric medications. They can exhibit hyperthermia, clonus, and they can also be confused. Patients who have had any trauma and they have a bleed in their head. Patients who are having thyrotoxicosis, their thyroid levels are elevated, can be hyperthermic, they can be quite agitated as well. And then obviously psychiatric problems like bipolar disorder, mostly in the manic patients, as well as schizophrenia. And then other infectious causes like meningitis, encephalitis, or tertiary syphilis, which isn't very commonly seen, can cause agitation and confusion in patients.
So yeah, it's the delirious hyperthermic patient is it's got a very wide differential. So it's kind of collecting information to try to figure out exactly what is going on. In the setting of someone that's known drug use and is displaying this, then yeah, there's most likely excited delirium going on. But just to illustrate that there are many different disease processes that occur with agitation and hyperthermia.
So we'll talk a bit about the pre-hospital management of excited delirium and what you guys can do when you're encountering these patients out on a call. So here's a case. So it's 2:30 in the morning and you get a call about a patient with bizarre behavior, and dispatch tells you that police are already present at the scene. And you drive out there, and when you get there, there's a naked man screaming at police in the middle of the street. There's a couple cop cars there already. He's quite agitated. And one of the police officers reports that they did taser him multiple times, but it was barely effective. He didn't even go down, just kept running around. Police get some backup that arrive, and they are eventually able to restrain the patient onto the stretcher. Then we have question 2 coming up.
So question 2 is, which position should never be used when restraining a combative patient? So your options are left lateral, prone, supine, or upright?
Steph, in the future, maybe we can play like some Jeopardy music for these questions.
That would be great. Feel free to add those, guys. All right, so we've had 78% voted, so I'll close that. And 94% of the audience has stated prone would be the position not of choice.
That's right. Yeah, you never restrain anyone in a prone position or face down. Restraining in general can present a number of serious complications. These patients are more likely to aspirate. You worry about positional asphyxia, especially if they're prone, and they might not be able to get a deep breath. Their face is down into a pillow or into the stretcher. Again, with the rhabdo, if they're struggling against restraints, they can get abrasions or bruising at the restraint sites. And then if patients are restrained for a prolonged period of time, like Dr. Lecter in the picture, they can be prone to deep vein thrombosis.
And again, rhabdomyolysis is going to be more of a prolonged issue with restraints themselves. Oftentimes these patients with excited delirium are often well on their way to the rhabdo process of acute renal failure, hyperkalemia, and then the restraints just further add to that if they are combative against the restraint, which we'll talk about in the upcoming slides about ED cares, why we often have to chemically restrain these patients when they are restrained physically because of the risk of rhabdo. So patient restraints in the BLS, so this is a BLS issue. So by all means, if you're not familiar with it, we'll just refresh your knowledge of the BLS version 2, section 8. A few pages of that. The biggest, we just kind of summarized the points here. Number one thing, safety is priority for yourself, so never put yourself in a dangerous situation. Again, it's going to be a team approach to restraining these patients. Police officers are going to be your best resource for that, and make sure they are available and let them do that, the muscle work there. Again, most of the time, you may get a patch for restraint. We may call the BHP for restraining order. The police may say that, yeah, this guy definitely needs to be restrained. So definitely, upon the advice of either or, restrain the patient. And of course, you may be transporting the patient and you may become violent en route to the hospital, then by all means that's a necessary action you need to do, is to restrain them to protect yourselves as well as the patient. And again, body restraints, the idea of restraining the chest, it can cause impaired respiration. And again, one of the factors that may lead to sudden cardiac death in these patients due to respiratory arrest or asphyxiation. Again, with restraints, best not to remove the restraints en route to the hospital. You're in a confined area. It's probably taken a lot of effort to get these patients restrained. The BLS definitely says if at the direction of a physician or police that restraints are to be used, then not to restrain them. If you decide clinically in the back of the rig that the patient needs to restrain, some wording as to you may use your clinical judgment to release the restraints. But again, think about your safety. Most of the transports are going to be short transports where the restraints are not going to cause much harm, and the risk to yourselves or to the patient by unrestraining them once they've already displayed this agitated behavior may outweigh any benefit. And again, frequent reassessment, so ensuring that the patient isn't becoming hypoxic or more obtunded, airway issues when they are being restrained. So just kind of the big take-home points from the BLS. I believe a couple pages of information there in the BLS regarding restraints.
So we're going to go back to the case now. So after the patient's been restrained by police in a supine position on the stretcher, he continues to fight against the restraints. He's still screaming, spitting at EMS and at police. You're unable to obtain any vital signs from this patient. Even when he's restrained, it's hard for you to even get close enough and take a pulse or a blood pressure. So what's your next step? There's a multiple choice question coming up that will be just for the ACPs, and we'll talk also about what the PCPs can do in this situation too.
And if you're a PCP, by all means, feel free to answer the question as well, but this question is related to the scope of the ACP practice.
All right, so third question's up there now. Everyone give it a shot. So what is your next step with this patient we've been talking about? So we're going to administer 2.5 milligrams of midazolam IM, patch to the BHP for an order for midazolam, tighten the restraints, or administer 5 milligrams of midazolam IM. All right, so we've got 81% saying they're going to patch to the base hospital physician for an order for midazolam. And then a smaller 16% who are going to administer 5 milligrams of midazolam IM.
Yep, so the answer to this one is definitely to patch to the base hospital physician for the midazolam order, because like we said, you haven't been able to get any vitals on this patient, you know, the ACP Auxiliary Medical Directive does list midazolam as an option for combative patients, but in there you'll notice they have to be normotensive to give this. And again, no reversible causes like we talked about, so hypoglycemia, hypoxia, or hypotension. So this would be a case where you can't really obtain any of these, so you could patch into base hospital physician for a recommendation on what to do. And we might say, you know, go ahead and give this patient midazolam, they're fighting against the restraints, or, you know, we might have you transport them in, just depending on the situation. And so again, that's just from your directives there, saying that it's a mandatory provincial patch point. And then the dosing for midazolam, it's the same through the IV and the IM route. You're going to give 2.5 to 5 milligrams. The maximum single dose would be 5 milligrams, and you can give it 2 times, and with a max total dose of 10 milligrams of midazolam. And then just for the PCP group, you know, what you can do in this situation, you're a bit more limited because you can't use midazolam in these patients, but you could call in to a supervisor. You could call for an ACP crew for backup, or you might have to just transport the patient in the restraints, and then we can deal with them when they come into the emergency department. But again, it'll be a little bit dependent on the situation, how agitated this patient is, and the safety you have coming, you know, have taken them into the ambulance, and obviously have police come along with you in the ambulance when you're transporting.
Yeah, definitely you'd want the police escort for this type of patient. Again, your safety is what's most important, so having the allied professionals with you as well for this type of patient when you are limited in terms of what you can do for them other than the restraints themselves.
And then when we see these patients, once they've been chemically restrained and they've calmed down a bit, we can gradually remove the physical strains in the emergency department. And when we do that, we kind of take one limb at a time. So first, you know, one leg, and then an arm, and then the other leg, the other arm, and just kind of keep reassessing the patient and see whether or not the restraints might need to be reapplied or they can continue to be removed. So we're going to go back to the case now. After the excitement has died down, the patient's had a bit of midazolam. You remember that the officers are telling you he was tased multiple times, and you assess the patient now that he's a bit more calm, and you see that the taser probes are embedded in his right chest and in his lower abdomen, because it fires off those 2 probes, so one's in the right chest, one's in the lower abdomen. He's now much more calm, he's cooperative with you. So, you know, the question is, should you remove these probes? You have to weigh the risks versus benefits. We'll talk a bit about when you should not remove the taser probes, and you're going to, you know, if the patient's calm, you might feel a little bit more safe taking these probes out, but remember, you're going to be dealing with sharps. You don't want to be dealing with those near an agitated patient where someone might get stuck with the sharp. And this is what the taser probe looks like. So this is quite magnified, but it only penetrates by about ½ a centimeter when it does go into these people. That's just a close-up view of what you might be dealing with. And for your directives with probe removal, that's the patient has to be greater than or equal to 18 years old and an unaltered level of awareness. There are no vital sign requirements for this. So we have a multiple choice question here about probe removal.
All right, so I've launched it. So the question is, from which of the following areas may a paramedic remove the taser probe? It may have been a while since we've seen this medical therapy, so it's actually a really good review. All right. 100% of the audience have said the abdomen. Well done.
Good. Yeah, that's absolutely correct. So that's out of these options, that's the only place that you could remove the probe from.
And the reason being, above the clavicles, that's going to be an area of more potential risk to anatomical structures. You know, the picture that we saw earlier in the presentation with the probe embedded in the eye, oftentimes that would require surgical removal because of the damage it would cause to the eye itself. The neck, again, a lot of big important vessels that sit in the neck and may be compromised, which may need a surgical fix as well. The genitals themselves, again, delicate structures, which oftentimes may require a surgical intervention to remove because of damage to the underlying anatomy going on there. And again, you know, with taser probe removal, is it prudent that the taser probes come out immediately? No. If it's interfering with your care to the patient, then, you know, it's something you can consider. If the patient is just complaining non-stop about them, then definitely you can remove them. Will you be faulted if you do not remove them? No, that's something we can do in the emergency department too. Again, it's a Sharps issue, so not a you know, a life or limb type of procedure. So you can use your clinical judgment if you wish to remove those probes. Just a couple of questions that we've had come in from the audience. One coming in, you know, so that a medic were to patch for the combative patient and require some midazolam for this because they're unable to get a glucose or obtain vital signs. And what kind of orders would you expect from the base hospital physician? Well, again, depending on this is going to be a decision made based on the patient at hand. And again, the physician you're talking with, you know, some may say, you know, follow your directive, give 5 milligrams as your directive states to 2 doses. You know, I've had a patch where I gave a larger order just based on the situation. Actually gave 3 doses because of the amount of excited delirium the patient was in. So I think that's why it is a patch point. It's going to be kind of a shared decision making. These are patients that, you know, you just can't write one directive for. Everyone's going to be slightly different. So it's hard to say exactly what that standing or what that order may be. Is 5 milligrams going to be enough times 2, so 10 milligrams a dose or a total dose? For some patients, that may be enough. For some, it may not be enough, and, you know, it may require a second patch in. So again, every situation is going to be unique, and that's why the patch point is built in there.
So this is just a slide discussing those contraindications to areas, probe removal, and if you do decide to remove the probe, there's some instructions there. You can cut the wires with trauma shears. Sometimes you have to just bend the wires and break them too, but again, you want to be careful you're not going to poke yourself with those. And stabilize the skin around the embedded probe, and then you can pull the probe straight out from the skin using forceps. Again, you're going to have to be really careful with this because it's a sharp object, and then dispose of the probe appropriately in a designated Sharps container. You know, the police have been involved in this case. They might want these probes back as evidence, so they might ask you for them at some point as well. So don't be surprised if they approach you about the taser probes, but just be really careful with them. They're sharp, so treat them appropriately. And this is a discussion of the first reported complication in the literature regarding tasers, and this is an individual who actually ate the taser dart that he had been tasered with.
So yeah, looking through the literature, this was the first case report of an injury or an adverse event with a taser dart. So someone actually ate it. And if you look at the study here, they actually have a qualitative section in the paper there asking, you know, kind of describing the case, and they asked him why he did this, and he said he believed that the police were going to kill him, and he swallowed one of the darts so that when the autopsy was done, they would know it was the police that actually killed him. So he is officially our Darwin Award winner for the day. And here's an X-ray. You can see the dart sitting kind of in this the right upper quadrant of the patient's left upper quadrant, the right upper quadrant when you're looking at the photo itself of that taser dart ingestion. So, you know, not an eye injury, not a genital injury. The first reported case was some guy who ate the probe so that they knew the police would have killed, that it was the police that killed him.
He's quite logical.
Very logical, yeah.
So this is a bit about what happens after you guys bring these patients into us in the emergency department. So we're going to talk a bit about our management. So, you know, again, we treat excited delirium as a medical emergency. This can kill patients.
And often, yeah, as medical, these would be a CTAS 1 type of patient. So these are ones where, you know, doctors are going to be called to the bedside to deal with these patients because it is a medical emergency, and these patients are at high risk for death themselves and high risk for injuring those around them.
Absolutely. Yeah, and again, they can present with multiple factors that could kill them, like the rhabdo, acidosis, the hyperkalemia, the hyperthermia. They might have a prolonged QT on their ECG, and they might even come in cardiac arrest if they've arrested in the field. So when we see these patients, we want to get that agitation under control. It's a very distracting thing. They're screaming, they're fighting, and again, they can injure themselves more as they fight. So our first-line treatment is to give a benzodiazepine, so midazolam or lorazepam, really whatever you have on hand, whatever you can get the fastest, we can give that patient. And we'll also often use an antipsychotic agent like haloperidol, or Haldol is the other name. And the nice thing about benzodiazepines and Haldols, they can just be mixed into that same syringe and just given to the patient in one poke. So what we'll often do is put 5 milligrams of Haldol along with 2 milligrams of midazolam or lorazepam into a syringe and administer that to the patient.
Yeah, every emergency physician has kind of their own cocktail as to what they use for chemical restraints. Some use this cocktail known as the B52. It has a couple other names, and I'm happy to tell you what they are. Off air, if you ever see me around, I'll tell you the names for them that we have. Just not politically sensitive thing to say on air here. And then, you know, some use ketamine. So everyone's going to have a bit of a different cocktail. There's pros and cons against using single agent, double agents. And you know, I don't think there is one best agent to use when it comes to emergency department care, and everyone has the reasons as to why they use what they do use.
And ketamine, like Matt said, is another option that we can use. They've looked at both administering ketamine through the intramuscular and the intravenous route, but there aren't a lot of studies on this, and it's really unknown what the optimal dosing of ketamine alone is, because a lot of these patients were also receiving benzodiazepines as well. So they have thought that the intramuscular dosing of ketamine should be 4 milligrams per kilogram, and then IV a bit less at 0.5 to 1 milligrams per kilogram. But again, this might have to be adjusted depending on the patient, depending on what other medications they might have had. There have been some cases of respiratory depression requiring intubation in these patients, but again, whether that's from the ketamine or from other medications that they might have been given, that's not yet known.
Yeah, I mean, that's a side effect of all these chemical restraints is respiratory depression. So, you know, something that we're keeping an eye on in the emergency department, and yet sometimes the amount of sedation that they do require ends up with them requiring to be intubated.
And then hyperthermia is another thing that we're going to need to manage right away in the emergency department. It's important to cool these patients right away, so we can start administering a couple of liters of normal saline cooled IV fluids, put ice packs to their groin, under their armpits, and then a really effective way of cooling people is with evaporation, so you can kind of have them misted with water and have some fans in the room cooling them off as well. And then with the rhabdo, we want to make sure we manage the complications that can present. So these patients have been fighting. They might have some increased potassium levels in their bloodstream. Later on, they can progress to renal failure with casts forming in the kidneys or cytotoxicity because of this. And they can also be acidotic from the lactic acidosis that they might get with rhabdo. So with this, we also manage this with lots of IV fluids. We're going to treat their potassium If we get their labs back, or if we see ECG changes, or just something we suspect, we can just start proactively treating that. These patients might also present with compartment syndrome in a limb if they've had some injury there, and then later on they might need dialysis if their potassium levels are very high, and if their kidneys have been involved in their renal failure. So I've got a few examples here of some ECGs on patients with hyperkalemia, but I want you guys to remember that this doesn't always correlate with the potassium level in their blood. So patients like this patient here with peaked T waves, this patient in particular did have a potassium of 7.1. This one here, they're starting to widen out a bit. They have peak T waves. They had a higher potassium level at 8.5, and then they start getting into the bradycardic, very wide complex, kind of progressing towards a sine wave look on their ECG. This patient's potassium in particular was 9, but again, you might have a potassium of 7 that can look like this, or a patient's potassium with 9 might look like the other patient who had a potassium of 7.1. So we can't really correlate that way, but this is just something that if we saw this ECG, we'd want to assume that's from the potassium, start treating that right away, because that's a life-threatening ECG.
And not something that you're going to be able to get in the pre-hospital setting in these patients. There's no expectation that you're getting a 12 lead on these patients. Mm-hmm. You know, these ECGs would be done in a restrained, chemically sedated patient in the emergency department. So no expectation that a patient who's in excited delirium has an ECG done in case they are in hyperkalemia.
Yeah, absolutely. We won't be asking for the 12 lead when you roll in with these guys. And then things that we'll do in the emergency department to treat their hyperkalemia, one thing is to stabilize the cardiac membrane with calcium. We can administer calcium gluconate, and then we can also try and shift the potassium back into the cells with giving insulin along with glucose. I often like to give the glucose first, just in case you end up losing that line, you haven't given them a bunch of insulin without glucose on board. We can give nebulized Ventolin as well. And then sodium bicarb, not the most effective way, but if these patients are acidotic along with being hyperkalemic, it could work. But I know with your hyperkalemia directives, that's not included, and rightfully so, because it's...
Sodium bicarb is kind of falling out of favor in terms of its effectiveness for the treatment of hyperkalemia. It was definitely part of the cocktail, but as more evidence is emerging, it's playing lesser and lesser of a role. And the latest kind of review of all the literature out there shows that sodium bicarb, at most has a role in acidotic patients, and even then, for its ability to shift potassium, it is small. So, from pre-hospital and emergency department care, the most important medication out of all of these is the calcium gluconate. We may use calcium chloride in the emergency department, but that is going to provide the cardiac membrane stability to reduce the risk of any arrhythmia occurring. And again, then we'll start shifting that potassium with insulin and Ventolin.
And then these patients might have to end up needing dialysis down the line too. And these patients we're often going to they might end up needing to be paralyzed and intubated to allow for treatment of these complications if they're still not cooperative, if they require enough sedation that they're unable to breathe for themselves. Often we do end up intubating them. And really the most important part of managing these patients is making sure everyone is safe, and anyone getting hurt in these situations, the safety of the staff, the safety of the patient.
A couple more questions that have come in, and one was asking about spit socks and whether or not they have an effect on respiratory compromise or lead to airway issues. And to tell you the truth, I don't know the research behind the spit socks themselves. I think, if the patient is saying that they can't breathe, then, you believe them. If they've got a spit sock on, and maybe switching it over to a mask with a face shield to prevent them from spitting. But I don't have an answer for the spit sock, something that we can look into for sure, but offhand, I don't know the literature behind the spit socks themselves. And the police do apply them sometimes to protect people from being spat upon. And the other question too has been about ketamine and the literature that's come out about the use in excited delirium as a sedative agent. Ketamine is one of these old drugs that's becoming new again. And in terms of the pre-hospital literature, looking at Australia, they use a lot of ketamine in the pre-hospital setting. In North America, it tends to be more benzos. The question is, what is the likelihood of ketamine coming to the pre-hospital environment in the future. Hard to answer that question. You know, I think as time goes on and we get more information, yep, there's always an evolution of the directives, and you know, looking at the literature, potentially ketamine may be a better alternative. It may be one of those things that is, you know, equal to benzodiazepines. So not sure when or if it is coming to the pre-hospital environment here in Ontario, but kind of from a cultural aspect, you know, it tends to be North America. Most EMS systems favor the use of benzos. In Australia, it tends to be more ketamine, but things change, and sometimes change takes time.
And so just a bit of a summary and some take-home points about excited delirium. Remember that this is a medical emergency. People do die from excited delirium, and always remember, keep a wide differential in these patients. Try not to get distracted by their outward appearance. Remember all those other medical causes that might cause their agitation or combativeness, and always be aware of your surroundings and be safe. Make sure you have lots of backup. Police are there. And look out for yourselves when you're dealing with these patients, because they're not thinking clearly. They can hurt others. And restraints can be used safely, and they can prevent harm to both the patient and the caregivers when they're used appropriately and supervised. And are there any more questions?
I don't have any typed in, but I do have one hand up, and I don't know if that's done purposely or not. So, Linda, I have unmuted you, so if you do have a question, go ahead and ask it. And she's disappeared, so I don't think that was done purposefully. I don't have any other questions from anyone that's typed in, and nobody else has their hand up. So I think that brings things to a wrap. So thank you to Matt and Megan for another great and very informative webinar. To everyone in the audience, we are planning on another webinar early in January. We'll be looking at bicarb and LASIK, so something that you guys have asked for, so we would like to provide that to you. We don't have a date yet, so do keep an eye on our website or on our social media and your work email, and we will send out that information as soon as we have it. Otherwise, thank you so much for joining us, and have yourselves a great day.
Thank you.
Thanks, guys.